what is more interesting, actually, not me, but the fellow who is coming after me. So this is long name. Bianca Golzio Navarro Cavalcante. Normally we just say that Bianca. And then I'm very happy to have here his husband, actually, who is, I mean, maybe interesting for you that he is a volleyball coach. How do you call this? I mean, beach volleyball? Beach volleyball. And then I don't know what is his present position, but at a certain point, I mean, he was the coach, actually, of the Hungarian national team. So he's a kind of very professional person. They also have a little baby girl who is not here, and I know her. I mean, quite well, actually. We met in project meetings, and so happy family. So Bianca is from Brazil, as you know, and then she actually completed her DDS in Brazil, and then she also did during this project, actually, this is as Hungary came across, actually, into their eyes, that Bianca had a fellowship in the University of Page, half a year or something like that, I mean, a couple of years ago. But that was her original program, or original PhD, as a part of her original PhD, not PhD, DDS program. Then she did a master's degree, master's program, which was jointly run by one of the Brazilian university and University of Pittsburgh. Actually, Professor Vieira is a very famous, actually, scientist on dentistry. I mean, a top researcher. So after him, actually, he came to us. So we should be very proud of this. And then finally, I became her supervisor when she came a couple of years to Semmelweis University. And as you will see, that what is the results? If something is wrong, just blame on me. And Bianca worked not only as a student, but she also she has been a methodological supervisor, which means actually that elder students support, and that's very important in the program, the younger ones. That she is even an important person in another way, that you see, we have registries and clinical trials, a group who actually guide the fellows actually to continue this. So she's involved in that one too. This is it. Thank you.
Dear audience, colleagues, and committee members, it's a great pleasure to present you today my PhD thesis entitled New Frontiers in the Early Management of Enamel Caries Lesions and Defects. Well, I am Bianca Golzio. I am a PhD candidate from the Department of Oral Biology, and my vision is a future where dental caries and enamel defects are treated early and also treated non-invasively. Detected early and treated non-invasively. And my mission is to bring evidence-based and clinically effective hemodialyzing agents into clinical practice. So in order to achieve this mission, my PhD focused on 2 studies about the non-invasive management strategies for enamel lesions and defects. Before going into further details, I would just like to show you a bit about the foundation that built our approach, which is evidence-based dentistry. So in a field that is evolving fastly and rapidly, we need to rely on high-quality evidence to ensure that our care is safe and effective. So EBD actually combines clinical expertise, patients' needs, and also scientific research in order to guide clinical decisions. And we do this by actually identifying a clinical problem, then evaluating the latest research and translating this back into clinical practice. With that in mind, we would like to show you how we have done this approach in my first project, which was about the efficacy of CPP-ACP on white spot lesions. What we are doing. So despite there was a large reduction in the prevalence of caries after the fluoridated toothpaste widespread use, untreated dental caries is still the most common oral health condition, affecting over 2.3 billion people around the world. But when treated early and detected early, this can still be hemodialyzed. So what could be then the solution? Well, we need to develop and study better new strategies that could enhance the efficacy of fluoride. CPP-ACP was one product for that. So it's actually derived from the milk protein casein, and it acts as a reservoir of bioavailable calcium phosphate. And studies have shown even to a 58% caries reduction after 4 weeks of use. But what the current guidelines tell us? So ADA actually suggests not to use CPP-ACP if other fluoride interventions are available. But we need to keep in mind that these guidelines still have a low evidence in the low number of studies included. And since these were published, new evidence, and especially RCTs, have been published, and still we have the question of whether combining CPP-ACP with fluoride could be more effective. So this question still remains today. And we have decided then to investigate whether the combination of CPP-ACP and fluoride would have a superior effect on hemorrhagizing those early caries lesions compared to fluoride alone. Here you can see our PICO framework, and I would just like to highlight that we used to measure hemorrhagization efficacy fluorescence-based methods, especially QLF and LF, but we also had a secondary outcome where we analyzed the visual area change. And we have hypothesized that this combination would be more effective than using only fluoride. Okay, so we have done the systematic search in Medline, Embase, and Central, and we were left with 15 illegible full text in the end. Just a brief overview on the outcomes before we jump into the results. So the fluorescence-based methods, we have first the laser fluorescence, which actually collects the emitted fluorescence from bacteria byproducts. It converts into a scale from 0 to 99, and it correlates to lesion depth. QLF, on the other hand, uses a camera, a software, and it will quantify the mineral loss by seeing the reduction in fluorescence, and it also calculates the area based on this fluorescence emission. So this is our first results that we have with the laser fluorescence. We have divided those results in 1, 3, and 6 months time points, and here we can see the comparison. I would just like to highlight here the first and the third months where we had a pooled SMD of minus 0.30 and minus 0.47. These were neither statistically significant difference between the groups, neither a clinically significant SMD. And later we can discuss further on this. But for LF, we could not find that neither of the groups were superior to one another. For QLF, now using the fluorescence loss, we can see, again, comparing the two groups, we can see first month, 3 months, and 6 months. And when we look at the pooled MD of 1 month and 6 months are 0.21 and 0.60, and we look at the forest plot, we can see that this was not statistically significant, favoring neither of the groups. And when we look solely at the MD, we also do not see a clinically relevant change on those. Also considering the heterogeneity of those studies, also considering the wide confidence intervals. And when we look at the 3 months, however, we see an MD of 0.58, which was a statistically significant difference, but now favoring the fluoride-only group. So different from what we have thought originally. But only at 3 months this happened. But again, we need to take this into careful consideration since the impact of this mean reduction of 0.58 in QLF could not have such a strong clinical impact. And as quality assessment, we have used the ROB2 tool to analyze the risk of bias, and we have seen to low risk of bias to even to high risk of bias in those studies. And we have assessed the certainty of evidence through grade assessment, which was still a very low evidence. So we need to keep this in mind as well when looking at these results. So in conclusion, what we could say is that combining CPP-ACP and fluoride was not significantly superior to fluoride alone, and actually that topical fluoride remains the cornerstone for arresting and reversing progressions of these early caries lesions. Of course, we need to remember that the certainty of evidence supporting of these findings is still very low, so further studies are still needed to confirm this. As trends, we have followed strict standards from Prisma and Cochrane. We have only included RCTs when we have done the analysis by multiple time points, so we can see the difference at 1, 3, and 6 months. Of course, it was not that possible in some cases. As limitations, we still had a low number of studies, low number of patients, a high heterogeneity of the studies, and also a short follow-up time considering. But especially what I would like to highlight is that unfortunately, the only possible clinical available methods, there are still indirect methods of measuring properly hemineralization. That's what we use, the fluorescence-based. For practice, what we should say then is that fluoride agents still remain the first line for the non-invasive management treatments of these early caries lesions, since what we see from CPP-ACP is actually a very limited additional benefit. And for research, future studies should focus on larger sample sizes, extended follow-up periods, and also maybe looking at more effective possible products that should be further investigated. As a second project, we have analyzed the non-invasive strategies for the management of hemineralization, but also hypersensitivity in molar incisor hypomineralization. So MIH is a qualitative developmental defect of the enamel that is characterized by these demarcated opacities, as we can see in the picture, and it affects at least one permanent molar, but it also has the involvement of other teeth, and it is also possible. So currently, there's a 13% worldwide prevalence of MIH, and it is often associated with a lot of aesthetic concerns, hypersensitivity, breakdown, and even reduction in the quality of life of those patients. So what could be a solution then? So we should take an early preventive approach that could actually minimize or even avoid those complications that I have mentioned. For that, non-invasive treatments need to be further explored specifically for MIH. The current EAPD guidelines that were from 2021 suggest no definitive clinical protocol for non-invasive approaches. Again, they have still a low number of studies, low evidence on the strength of recommendations, but new evidence since then has been published, and still no other quantitative approach have been done on this topic, and this is the first one to be done. So our aim was to understand which non-invasive strategy between the available ones were the most effective for hemineralization and hypersensitivity for those MIH teeth. And the outcomes that we have used for hemineralization were LF and QLF. And for hypersensitivity, we have used the different pain scales that are used clinically. And we have hypothesized that CPP-ACP would be the most effective between the options. We have done a systematic search again in Medline, Embase, Central, and we were left with 16 illegible full texts. And we can see here in this first figure about the laser fluorescence values, where we are comparing now CPP-ACP specifically versus fluoride-based methods. And we have stratified these results into the severity of the lesions, which is really important to note. So we have mild and severe lesions, and we had one study that actually combined mild and severe. When we look at the pooled effect with the MD of minus 3.80, we see that there's no statistically significant difference favoring neither of the groups. And we should also take a bit of careful consideration when looking at the potential clinical benefit that this number could mean in the LF. Consider the heterogeneity again, consider some outliers, and also the very wide confidence interval. But interestingly, when we look at the severe lesions, you can see an MD of minus 11.07, which would mean a decrease of 11 points in LF scale. But again, we should take this into careful consideration because the confidence interval was very wide, and we had an outlier that we can discuss about this later as well. And the second plot, we actually don't see a comparison between an intervention and control, but we do see here the mean change from baselines separately for each agent. Since this was a first exploratory analysis on the topic, it was important for us to see these mean effects from each product. And I would like to highlight two here, fluoride varnish and CPP-ACP. So we can see from the mild lesions that the mean effect of those studies included was a minus 2.74, while for CPP was minus 1.40. So a reduction of 1.40 and 2.74, which could not mean something so important clinically. But when we look at the severe lesions, that's what when it becomes interesting, we can see that the severe lesions, we had a mean reduction of minus 9.88 for fluoride varnish, and for CPP-ACP, minus 4.83. Despite the mean in the fluoride varnish being a larger mean reduction, we need to also consider the wide confidence interval. And for this CPP-ACP, we can see that we had a narrower confidence interval, which could mean that we could trust a bit more on those results. But again, this is only an overview to position what are the current efficacy of those methods. And finally, for hypersensitivity, we have done this in the VAS scale from 0 to 10, and we have compared CPP-ACP to fluoride varnish. That's what was possible to be done. So what we can see here is that we had that CPP-ACP actually outperformed fluoride varnish. It was a statistically significant difference, and also this MD of reducing 2.36 points in a 0 to 10 scale, it is also clinically relevant. And the quality assessment was done both by Robbins Eye tool and ROB2 tool, and we have done the grade assessment that was also very low. So in conclusion, we can say that this have not demonstrated a superior effect to fluoride in hemorrhagizing MIH lesions, but we have actually seen that CPP-ACP was more effective than fluoride when reducing actually hypersensitivity. We have also explored other agents here, but despite them showing a mild to moderate effect, there were a low number of studies, maybe 2, sometimes only 1, sometimes 3 studies, and we can still see that the evidence on this topic remains inconclusive. We cannot say much about these other agents. So we still need high-quality RCTs with a longer follow-up time and to see better the effectiveness of these combinations, and also assessing by lesion severity. So as strengths, we have followed, again, a strict methodology, and we have done this subgroup analysis based on the lesion severity, which matters since we need to see what's the difference between these two. And this is the first quantitative analysis on the available MIH strategies. So as limitations, we had a low number of studies in patients, a short follow-up time, a high heterogeneity of studies, and also the study design, since we had a lot of non-randomized trials, sometimes prospective trials, we did not have a control group for a few analyses. And also, we have used surrogate outcomes for the fluorescence-based methods, but also different pain scales were used to assess hypersensitivity, and in the end, we had to summarize this into a VAS and standardize to a VAS scale. For practice, what we could say is that CPP-ACP should be prioritized for non-invasive management for hypersensitivity, especially in moderate to severe cases. The other agents, they still lack clinical relevance to say anything for the practice. And for research, what we can say is that further robust RCTs are needed for each agent. We need more uniform and longer follow-up time points as well. And also, we would advise to use SCAS as the dentin hypersensitivity scale, and also to characterize better the lesion characteristics, since that matters a lot in MIH. Also, that further novel therapies that were underrepresented in this study should be explored, such as SDF and low-level laser. Finally, these studies were published both in Q1 journals, as you can see here. And during the PhD, I had a total of 13 publications with a cumulative impact factor of 40.7. And also during this time, as additional activities, I have done lab work at the Department of Water Biology for a few years. I have also participated on international conferences, delivered lectures, and actually worked at CTM as a scientific methodology supervisor for over 18 students in the past years. Finally, I would like to extend my gratitude to my amazing supervisor, Professor Gabor Varga, also to Professor Gabor Gerber and Professor Peter Hatch for their unwavering support and contribution, also to all my department of our biology colleagues, CTM colleagues, and finally to my wonderful family, Leo and Alice. Your support was amazing for me. And I would like to leave you with the quote that it is this one: failures, repeated failures, they are finger posts on the road to achievement. One fails towards success. Thank you very much.
First, let me hand over my high appreciation and acknowledgement for this nice work. And energyful presentations as well, because it was excellent as well. And the credit goes not just only to you, but your background team as well, because it looks like that the work in the translational medicine, it's not only one person responsibility and work. It needs a high and a wider, bigger team to be able to introduce and making and completing a high success work. So before I'm kicking off the question intervals of the procedures, let me share with the audience some information, because I would like to trigger and foster the audience to make questions. But in the second half, in the first half, I'm turning to my members of the committee, mainly for the opponent to share some professional questions joining to the topics. Who will start the questions?
Thank you for your very nice presentation, for your perfect English. Sorry for my broken English. Maybe you can give some comment based on your research. What could reduce the heterogeneity in study designs? What could be like directions for the future?
Yes, regarding both of the studies, you mean?
Yeah.
Yes, thank you very much for your question. Actually, the main issue is that, for example, in the first study, we could have only RCTs, which was much easier to have a more high quality control in a sense. So to have a proper randomization, to have control groups, while for MIH, since we had still there's not a quite clear direction, I think, to where to go. So it's really hard for people to design properly a study. And also to think the patients is also a bit of a challenge to have enough patients to be able to randomize and everything else. I think it just ends up being a bit of a clinical, do what we have here. So I think in the first section, it's a bit easier because we have more capability of doing a proper RCT and just having a better homogeneous, I would say, samples on that sense. For MIH is a bit of a road to go, but I think it's a first good step to look at this and see the directions into the possible agents that we have, and now focus more in a few agents that seem to be more relevant.
Mm-hmm. Do you think that maybe split mouth design or crossover design would be something that we should target in the future in order to reduce the heterogeneity?
The problem with the split mouth studies, for example, in the first study, I have excluded those ones, is the carryover effect. So we cannot know for sure. And especially for MIH, since we could have varied lesion severities, it's really hard to tell whether it was because of that one that you applied on one side or because of the carryover effect of other agents. So in a sense, this could actually bring more confusion to the actual clinical benefit of those agents. So this needs to be taken care into careful consideration. In the second study, we had actually one study included that was a split mouth because, of course, we did not have a large number of studies and we had to include this one. But this is a potential confounder as well.
Yeah, and what about a mode of application of the product? Does it contribute?
Yes. First point. Everything that is done at the professional level, it's easier to control. So of course, if we do, for example, the fluoride varnish applications, that's much easier to control. But when we have CPP-ACP, and I think that's the biggest problem, we don't know if it's exactly the lack of efficiency of CPP-ACP or maybe the lack of compliance from the patient. So it's really hard to tell. And I think in the end, that's why when we see the first study, we cannot justify enough clinical benefit to say, okay, patient, here is one more product for you to use and that you're spending more. And then it's just one other thing that maybe the patient won't comply to. So we need to take this into consideration as well.
Thank you.
Thank you.
Oh, thank you for your very interesting and fascinating presentations. And I have one question, because MEH, you said that it's some kind of developmental defect. Yes, and if it's developmental, I assume that it happens before tooth eruption. And why do you expect that fluoride and calcium phosphate may be effective here in this case?
Thank you for your question. So when I say here about the effectiveness is not on preventing MIH to happen, but to mitigate MIH lesions in a sense. So in that sense, MIH lesions, they will happen if the patient has MIH, but they will start very mild. So they will not have cavitations. It will be statically not that bad, so whitish appearance. But then when it gets more severe, and because of the histological properties of the enamel of the MIH, which is more porous, is more prone to breakdown. So all of this could happen. So in a sense, these are only to deal better with MIH and give the patient a better quality of life and avoid any other problems and restorations to be done, avoid hypersensitivity and pain on those patients, and even leading to tooth loss, which happens a lot with those MIH patients, but not to actually have an impact on MIH not happening in first place. Thank you.
One question struck me because the hypersensitivity depends on maybe the extension of the dental hard materials involvements. And what is your opinion that the heterogeneity is coming from this, and which methods may help in the identifications of the extension in terms of vertically and horizontally the hypomineralizations, and maybe how influence this extension the efficiency of the CPP-ACP, sorry, abbreviation is very complicated.
Yes, it is.
Because in case of this is a very critical point of the assessment, because the extension of the hypermineralization determinations depends on maybe the radiology. We have some expert in the committee as well. And what is your opinion? How we can exclude this questionable situation, or how we can make a...
You mean about the, about the extension?
Extension, how we influence the efficiency of the materials, because if we have a larger extension, hypermineralizations, maybe the hypersensitivity can be much more higher level. How we can make correlations, concatenations between the two phenomena.
Thank you very much for the question. So of course, more severe cases that have more hypersensitivity. That's why it's really important to actually see the different results for mild and severe cases, because then severe cases, for example, there is spontaneous hypersensitivity, while mild cases are usually provoked. So this is already a bit of difference that we could see here from the two. But also analyzing the extension of the lesion, that's why I would advise to have maybe a different approach to depending on the lesion severity, which is, again, comes back to the importance of having proper MIH assessment of lesion severity. So it's really hard because, again, it's a topic that is still very new. And then we don't know exactly, we have EAPD criteria at mild and severe, but it's still very, I would say, very broad in general. So we have to be careful with this.
Yes, thank you so much for a very didactic, very clear presentation. Just because he was asking the question, I was triggered to the radiological diagnosis of the hypomineralization. How far can you rely on radiology to discriminate the severity of the hypomineralization?
Yes, thank you for your question. And interestingly, we have brought here only the fluorescence-based methods, of course, because in a sense, nothing against radiology, but we need to be careful when we are just using this as a solely method to visualize these, especially early stages of MIH. In that case, it's really hard to tell by radiograph. But of course, it could help into when we have a bigger extent. But especially here, when we are measuring mineralization efficacy, we need to know the small details that we cannot often see in the radiology, and in radiographs, we cannot see those. That's why, in a sense, when we are studying the topic, we need more of those adjunctive methods to measure. And of course, not only fluorescence-based, but we have others that are being further studied now. But still, the ones that when we read the literature, we see mainly those ones, of course, because they're easier to apply, and it's been quite some years of those. So it's good, but I would say to detect small defects, they're not the best. And also to detect the efficacy of those agents, it's really hard to tell.
Thank you so much.
Congratulations for your progress and presentation. If I may ask you about the sensitivity outcome, because I am now facing it, I saw that maybe it is judged by FDI criteria or USPHS criteria. So how did you manage this, subgrouping or what?
With the hypersensitivity measurement? Okay, thank you. So in that case, hypersensitivity was measured by pain scales. So what we had VAS, which is just 0 to 10 scale, but we also had, since there were mainly kids in some of those studies, we also had a facial scale, which was WBFS, but is a 0 to 3. Then we had, or 0 to 4, and then we had also SCAS, which is based on cold air sensitivity, so it's provoked by air, and is also 0 to 3. So we had to standardize those before actually putting this into the forest plots, so we could have a 0 to 10 scale and actually be easier to analyze all of them together and just have a more clear clinical interpretation of those findings.
So in single forest plot?
Sorry?
In single forest plot?
Yes, so we have done this before the forest plot. And that's why we can still use the MD, because we have done this before. So we have standardized the scales, all of them, just by multiplying, basically. It's very easy.
Thank you.
Thank you.
Thank you very much for the nice talk, and also thank you for being so transparent about the limitations of the study, one of your limitations that you mentioned is the relatively low number of studies included in the meta-analysis, and you also mentioned or wrote in your thesis that with a low number of studies, it limits the interpretation of the results, and also meta-analysis, random effect meta-analysis works poorly with small number of studies. So my two questions is, why is that? I mean, why meta-analysis and random effects meta-analysis works poorly with a small number of studies? And my second question is, what do you consider a sufficient number of studies, and why?
Yes, very good question. Thank you. So first of all, the biggest point here I mentioned also that we had a low number of studies is since we have divided the subgroups by time points, we had even less studies. And since we were doing RCTs and comparing, intervention to control, so it was decreasing the study number. And the main problem that we have is that it's really hard to tell whether the pooled effect that we see is actually consistent or just because of the low number of studies. So we cannot really tell if this was because we have selected, 3 studies, but if we had a much larger pool of studies, it will be harder to see that trend. And we are seeing the plot and seeing whether we could have, in the end, a more concise and more narrow confidence interval as well, because that even matters more than the pooled effect itself, because we need to know that it could fall into any of those intervals. So there are many aspects that we need to take into consideration, and the random effect is used basically when we have a heterogeneity of the studies, and we are assuming that they're different between each other. So we had these 2 problems. We were assuming that there was heterogeneity, that's why we had to use a random effect model, and when we have a low number of studies, these confidence intervals and also the pooled numbers, they could be distorted, and we have to take be careful with this. The second question?
The sufficient minimum number of studies.
I don't know. It's a very good question. What could be sufficient? All of them, as much as possible. But I think, for example, at least to have a proper funnel plot analysis, for example, where we can see which studies they're falling out of that. We have 10. I'm not saying that you should have 10 to have a meta-analysis, but this is something extra that we can see how these studies deviate, and we need at least 10. But the higher number, the better, I would say. Please don't kill me SMSs. But that's it. It's really hard to tell exactly a number.
Thank you very much.
Thank you.
In my opinion, on the behalf of the committee, thank you so much for your excellent and very competent answer.
Thank you.
In my opinion, no question left unanswered. And, I should keep the normal schedule. Now the opening intervals of the thesis defense is ready, and the committee is leaving because we have time to assess your performance. And we need from the audience 5 or 10 minutes for finalizing your assessment, because we have to give points for your performance. Thank you so much.
Thank you very much.
And congrats again for your nice presentations. On the behalf of the committee, we are finishing the assessment. And let me hand over my great congratulations for your maximum points, because you got the 25 points, which means 100% performance assessment. Stormy applause, please.
Thank you.
And I have to pitch down what does it mean. Your qualifications of degree will be summa cum laude.
Thank you.
Lastly, but more importantly, on the behalf of the committee, we are wishing a very joyful, fruitful career in your profession, in your scientific work, and in your private life as well.
Thank you very much. Thank you, all the committee members and CTM. Thank you.